Welcome to A Stride Above podcast, where our commitment to excellence in equine health and athletic performance unites us. Join your host, Dr. Alberto Rullan, as we trot through the essential topics that matter most to you and your equine family members. With over 15 years of experience in equine sports medicine and rehabilitation, Dr. Rullan is dedicated to navigating you through the latest innovations and essential insights in horse health. Together, we'll ensure that you and your horses always remain a stride above the rest.
Welcome back to another episode of A Stride Above. In our previous episode, Dr. Colton and I talked about arthritis, the definition of arthritis, some of the treatment of arthritis, and joint supplement. Thank you very much, Dr. Colton, for another episode.
Thank you.
And this time, I want to ask Dr. Colton on experiences and treatments on how does arthritis affect uncommon parts of the body. Sometimes we think of lower limbs most of the time, feet, fetlock, knees, stifles, but we forget that arthritis could actually attack the upper body. We all have a grandma, an uncle, or yourself with neck pain, back pain, right? And that also has to do with arthritis. So how do you go about working up a horse that comes for poor performance? And how do you go about determining where is the problem of the horse and how does it affect if he has arthritis in the neck or the back or the sacroiliac or the lower limb?
Excellent question. History from the owner, client, trainer, whoever it is that rides the horse the most is obviously very important. What are they feeling? What are they seeing? What are the performance limitations that are bringing them in? That can definitely help to key you in or at least give you some valuable information. So having that good communication relationship with the rider, owner, trainer, very important. Good clinical exam, obviously, palpation, range of motion, evaluating for any stiffness, soreness, pain, muscle atrophy, especially if we are talking about neck and back. And then, obviously a good full dynamic exam, watching the horse move around, watching it in work, watching it doing whatever its job is. That can definitely be very enlightening and help to key you in if we're looking at something that is more likely to be lower limb versus something that's higher up in the neck or in the back.
So let's give a practical description of, let's say we have a middle-aged quarter horse who is in some sort of athletic performance. What will make you think, what action on the horse or what clinical symptoms will make you think the horse will be lower limb versus epaxial muscle, I would call it, or epaxial skeleton or neck and back?
Yeah, so I think part of diagnosing axial, skeletal, neck, back issues, you have to start by ruling the legs out. That's a big part of it, because we can see one complaint that I'm sure we both get very commonly is reluctance to pick up one lead versus the other, going wide around a barrel when we didn't previously. And so, ruling out soreness down in the lower legs or some arthritis. An issue that can be treated in the lower leg is a part of the full workup. And then if there's really no issues down in the lower leg, start to look higher. And again, it comes down to a good clinical exam, range of motion, imaging, diagnostic imaging, while a little bit more difficult, a little bit more technically challenging in the neck and the back. It's doable and then gives you a lot of valuable information.
And we obviously can do this with diagnostic blocks, joint flexions and all that. And I get this constantly, how do we explain to our clients when the horse has an obvious head bob, and we start blocking from lower limb all the way to the upper limb, and we can never block out the lameness? What do you tell your clients when that happens? Because they get very frustrated when this happens.
Yeah, it can be very frustrating for the client because, they're there for answers. They want to see something. You're doing things, but you don't seem to be changing the clinical outcome throughout the exam period. But with joint blocks, nerve blocks, we can only go so high, nerve blocks specifically, before we start to get into areas of the anatomy that you can't block due to safety reasons or just physiology. And at that point, sometimes you might have to treat an area of suspicion and see if there's resolution of clinical signs. But no, I agree that sometimes that can be frustrating for both the client and for us.
Can neck cause head bobs?
Absolutely.
How does that happen? What do we tell our viewers?
Well, it can be a variety of different things that can result in a legitimate head bobbing lameness from the neck. It can be problems with nerve compression. So in the neck, specifically in the base of the neck, there are nerve roots that go down to the forelimbs, and if there's compression of those nerves, there can be significant dysfunction of those nerves, and then secondary significant dysfunction of those muscles, and that can cause significant gait abnormalities. It could also just be pain. It can be they're stiff, they're tight, they're painful. There's bone pain from cervical neck joint arthritis, and so that they can alter their gait to try to brace and protect that area that's painful, and that can absolutely cause head bobbing lameness.
How do we treat them?
A variety of different ways. I mean, a lot of the ways that we've been talking about: direct intra-articular, joint injections, physiotherapy, especially for appendicular things, rehabilitation, shockwave, magnawave. There's a lot of great options for axial skeletal neck back problems.
Is there anything in the neck that so the neck has joints just like any other lower limb? Is there any product that you are concerned or don't put in necks versus lower limb, for example?
I wouldn't do joint blocks.
Okay.
Some people do. Some people do. But with the neck versus other joints, you have the added complicating factor of the spinal cord being right there.
Yeah.
Nerve blocks, in my opinion, are there. There's a certain risk there. The spinal cord's one large nerve, more or less. So
I did go to an AAP once, AAP convention, and they were talking about how to block the nerve facets. So I came out of that AAP convention. I was very young and very enthusiastic, and I went ahead and I blocked the C6, C7 with some carbocaine, and I also did C71, so the cervicals, lower cervical at the base of the neck, like you were talking about. And that horse became very neurologic. Very neurologic. This horse looked like a wobbler. It looked like it was going to fall down. I was extremely scared. I was so scared of this horse that I patted the stall very well in case of it fall, and I let him be. So after that, I haven't done carbocaine anymore. Now, I don't know many people blocking them, but I think some people are blocking them. Very great, very very good for you if you're blocking those joints. Very good. Yeah, I agree 100%. So that was very interesting, and I still get the question, even though as much information as we give to our viewers, I still get the question of that they're actually joints in the neck, and they get arthritis just like any other joint
absolutely
in the body. So it's very good that you touched on that. So that was Dr. Colton's opinion and knowledge on joint injections of the neck, arthritis of the neck versus the lower limb. I hope you enjoy it. Hope we add some value to you. Remember, if you like what we say, give us a review, thumbs up. If you don't like it, just tell us and we will change it. Thank you very much for staying with us. And thank you, Dr. Colton. We appreciate it. You have a great day.
Thank you.